Okay, again, we're talking about injuries that can lead to instability. Tayson?
All right, we have a lot of soft tissue there in the lateral or ulnar side of the wrist there.
Understand.
TFCC is probably torn lunotriquetral ligament.
Have to see that a
Not,
little better. We've got some bone edema there, huh?
yeah. Um, yeah, just a lot of amorphous tissue.
And then you can see a defect in the membranous portion of the scapholunate ligament. And we really need to look at the axial images to look at the dorsal and volar. Okay.
Is that blood there, John? Or
I don't think so, John. I think that's just soft tissue edema.
Okay, so 17-year-old male, wrist pain after sports injury. We see a defect in the scapholunate ligament.
So they're in the membranous portion. Here's a 3D 1 millimeter non-skip image, 3D cube.
I think the dorsal band looks a little irregular.
A little regular, a little thickened, but it looks like it's intact. The volar band looks okay. And this was a stable membranous tear. Okay, Annie?
Looks like again we see a defect in the scapholunate ligament.
Yeah, this is an arthrogram. And then we also see that the volar, it's a little bit irregular and a little bit frayed. But dorsally, we can see there's a tear, that dorsal ligament with separation between the two. And that was an unstable tear. Robert?
All right, so we have some radiographs of the wrists, and the left wrist, all I see is maybe some degenerative changes of that triscaphe joint. Yeah, some cystic change there. And here, looking at the scaphoid, it looks like it's flexed a little bit.
Maybe a little bit, but it's probably within normal limits. Here's the MR scan.
Here, on the MR, it definitely looks like a tear of that scapholunate ligament with some widening of the interval there.
Right. Markedly widened here. And here, yeah, and this was an unstable tear. But you still don't have a lot of DC instability at this point. Okay.
All right. So the membranous scapholunate looks a little irregular there. Diastasis, dorsal band, yeah, very indistinct.
Right. Yeah. And this was actually an arthrogram, and you see there really isn't a lot of fluid going in, distending the metal compartment. And this was a negative arthrogram, but this was an unstable injury. So just remember that you can have chronic unstable injuries where you get fibrous kind of membranes develop where you don't have free flow of contrast. So again, always be somewhat skeptical of arthrogram, especially in chronic disease.
Okay.
Okay, so question of a scapholunate ligament tear.
So this is a low field scanner of the stir sequence.
Sure, some increased signal there, scapholunate interval, but no widening.
Okay. And they did an arthrogram here. And this is a coronal gradient echo T1 weighted sequence on the arthrogram. These are 2 millimeter thick contiguous images.
I don't see contrast in that midcarpal joint space.
So we don't see contrast here. We don't see any contrast going here into the distal radioulnar joint. Maybe a little bit, be a little concerned there could be a little bit of a partial tear of the ligament there. But here again, as you say, the arthrogram really doesn't show a tear. Okay, and then here's just another example of a DC pattern, diastasis and a big tear involving the ligament. And we already talked about the instability patterns of the lunate. So, so just to recap this, here's the normal, where the capitate is kind of collinear with the lunate, which is collinear with the radius. Perilunate dislocation, the capitate is dislocated posteriorly. The lunate more or less stays in similar position. Mid-carpal dislocation, the lunate subluxes a little bit anteriorly, the capitate a little bit posteriorly, and the lunate, the most extensive instability lesion, you have anterior dislocation of the lunate. So, Danny, what do you think of this case?
So it looks like their lunate looks anteriorly subluxed and rotated.
Yes,
And the capitate morphology I can't really make out here. So maybe a fracture.
yeah, it's hard to say. So this would be somewhere probably in between a midcarpal and a lunate dislocation in this particular case, because it's a little hard to see. Here it looks like the capitate is relatively normally positioned, and we have dislocation of the lunate, and this was thought to be a lunate dislocation, which is the most unstable of the lesser arch injuries. Robert.
All right, so we have a 17-year-old snowboarder, and I don't see much of a lunate at all here on these coronal images. Yeah, there, it looks like it's dislocated. This looks like a straight lunate dislocation. The capitate still looks like it's pretty well aligned.
Yeah, so this is another lunate dislocation. Good.
All down left chest pain. All right, frontal radiograph. I don't see much. There's. This is a mid-carpal dislocation.
On the
Yeah, it looks like the capitate is kind of middle and is pretty much oriented properly with the radius, and then we have the lunate out here. John, did you want to say something?
yeah, I was going to say the lunate is anterior.
Yeah, right over here. Then if we go to the CT scan, this is what it looks like.
A small fragment in addition to that. I'm not sure
Yeah.
where that's coming from.
Yeah, so this is another lunate dislocation.
Okay.
Yeah, well, the capitate is pretty much collinear with the radius. Okay.
Okay, 8-year-old male with wrist pain. I see edema in the proximal scaphoid.
Think about here.
Yeah,
So
everything looks
we have
well.
a scapholunate ligament tear here.
Okay, so that's a T1 on the left.
This is a T1 on the left. This is a low field scan, and this is actually a gradient echo T1. This is a stir.
Mm-hmm. So that low signal could be edema, right, on the T1.
I guess it
Proximal
could
saver.
be. Notice that nice rounded appearance here. Here's a gradient echo sequence.
Yeah, loss of that normal bone
Here
signal.
there's the axial images. It's an 8-year-old, and he's not yet ossified the proximal scaphoid. So just be careful. This is a normal finding in an 8-year-old. Okay. Danny?
All right, skeletally immature patient again. I don't see obvious widening of the scapholunate
Okay.
interval. Kind of at the metaphysis of the radius. I don't know if that's a fracture.
No, that's not a dislocation. I can assure you that.
Okay. Yeah. So now sometimes these Pediatric fractures can be a little bit subtle, but we can see the cortical buckling here of this.
In this age group, you don't tear ligaments.
Yeah.
Extremely rare.
And here you can see the edema on the MR scan in the area where there's the fracture. So you don't want to look at the sagittalus and see the degree of angulation. And we can still see there's some roller tilt to the distal radius. And oops.
Torus fracture.
Yeah. Yeah. And then, by the way, I'm just going to point this out so I don't. There was also the concern about here whether this is scapholunate ligament tear, but this is another situation where it was a young kid with a torus fracture, really a Colles type torus fracture, and this is just a non-calcified cartilage in this location here. And again, it looked like it could have separation there, but this is uncalcified cartilage. And then we already talked about the progression. If you have a scapholunate ligament tears, you kind of get progression of the degenerative disease, but we've already discussed this. And here's just another example of diagrams and another article on the progression of degenerative disease. Okay, Robert.
All right, so we have a 45-year-old male with chronic wrist pain and question AVN. Yeah, it does look like there's a lot of degenerative change on the distal radius and proximal scaphoid and lunate articulation. Yeah, right there.
So that's a plain film. Here's the MR.
Yeah, looks similar. There's a lot of edema and chondromalacia, full thickness chondral loss of that distal radius and proximal scaphoid, some edema there.
A lot of eburnation, all the joints here. So what do you think is going on here?
I don't necessarily think it's AVN. There's edema there, so I think it's at least perfusing. I want to say there's probably a chronic tear of that scapholunate ligament, and
Yeah, so chronic tear of the scapholunate ligament, and then this would be early degenerative disease over here, but once you start getting degenerative disease in these areas, we're really talking about a more extensive degenerative disease, a lot of joint space narrowing between the capitated lunate and hamate and lunate, a lot of eburnation of the bones. So this is really scapholunate ligament tear with kind of developing advanced collapse with extensive degenerative disease. So this has a very poor prognosis. On the sagittal image here, you can see a DC tilt to the lunate and marked joint space narrowing here. So this is what you see in scaphoid lunate advanced collapse. Characteristic findings. And here's another example. Right here we can see more compression of the scaphoid, degenerative disease, again involving the scaphoid articulations, both proximally and distally, as well as the capitate lunate and the capitate hamate articulations with a DC pattern. And again, you can see the marked loss of articular cartilage, foreshortening of the wrist. So another typical example of scapholunate advanced collapse. Okay, a more subtle lesion here.
So yeah, the scapholunate ligament is torn, and then the scaphoid is displaced proximally and eroding at the
Right.
distal
It's
radius.
rotated, it's eroding distal radius. The capitate is really foreshortened. It's really almost, the capitate is actually articulating with the radius here from the separation, marked instability as we can see here. And the lunate is markedly displaced. So this is even a more severe example of scapholunate advanced collapse with destruction of a lot of the bones. That was with rheumatoid arthritis.
Right, so here, sagittal images. Looking at the image on the right, we have some bone erosions anteriorly there. Um, yeah, maybe some synovial thickening.
Good.
Could be, inflammatory arthropathy.
Yeah, so this is a DC orientation of the lunate
Mm.
and someone with chronic arthritis, and this was another rheumatoid arthritis patient. Good. Danny?
All right, so axial wrist markers on the ulnar side. Looks like a cystic structure surrounding the ulna.
So it says here maybe a little bit of subluxation of the ECU. We go to the sagittal images, that's what we have.
So there's osseous involvement, it looks like, with
What?
it looks like there's some osseous involvement as well
Osseous
of
involvement
the
of what?
radius.
What?
Of the radius?
You mean
Or
down here?
yeah, below that, below that.
What?
Below that?
Down here?
Yeah.
Well, here we're partial volume, just the edge of the radial.
Oh, okay.
This is the distal radioulnar joint space. This is muscle fat.
Oh, okay. So
And what we do see here, if we look at
VISI.
the lunate, we have a VC pattern where the lunate is kind of subluxed dorsally and angled volarly for a VC pattern. And this is, and this patient had a lunotriquetral ligament tear. Robert? These are gradient echo images on a low field scanner.
Okay. Is this an arthrogram?
I don't think so.
Okay. Here, let's see. I mean, there's some decreased signal within that distal radius. I'm not sure if that's real.
I think that's just a susceptibility artifact.
Okay.
What do you think of over here?
Looks like there may be some fluid in that lunotriquetral ligaments. I'd be concerned about a tear.
Yeah. So lunotriquetral ligament tears can often be difficult with our standard MR imaging. This is a 1 millimeter no skip image, and it shows actually very good contrast at 0.2 Tesla, but the contrast is really terrible when you go to 1.5 and 3 Tesla. So you can't really use these gradient echo techniques very well because you have too much susceptibility artifact at higher fields. But these are actually very good at looking because you get these very thin cuts without any separation between them. You can see these little avulsions very nicely. And since you don't usually get diastasis at the lunotriquetral joint, these can be difficult to see on higher field imaging. So you have to be very concerned about that. This is about the only area where I found these low field scanners to actually have an advantage. But we don't see very many lunotriquetral ligament tears, so it's not advisable to recommend people get low field scanning. Okay, Tayson.
I do see some fluid kind of adjacent to the scaphoid there and in the prestyloid recess and maybe the
Over here?
yeah.
Scaphoid's over here.
Yeah, and then
Okay. I think this is an arthrogram.
okay.
It's a 1.5.
I think I see the scapholunate ligament is intact. There's some increased signal within the triangular fibrocartilage. And
There's a little bit of contrast here. A little bit of contrast going through the scapholunate interspace there.
yeah.
And this turned out to be a surgically confirmed lunotriquetral ligament tear. Again, notice here, you're not seeing a diastasis. You get a displacement of one bone with respect to the other. On the actual sagittal images on this patient, there was not yet any VC instability.
Hmm.
So if this is what you're really concerned about, arthrography can be helpful. But this is a very uncommon injury.
Okay, so here we see on the sagittal, we see a VC deformity.
Okay.
Widening there, the scapholunate interval, early SLAC changes maybe.
Yeah. So we had, and we also had a triquetral fracture in this particular case. So occasionally with a scapholunate dissociation, you can actually get a VC pattern rather than DC pattern. And so you can look, there may be other injuries, and here we've got a lot of degenerative disease and an actual fracture, an old fracture of the proximal triquetral. Okay. Danny.
All right. On the T1, I see a little convexity at the distal radius.
Yeah.
Yeah, with some edema on the fluid sensitive sequence
Yeah. So
or cyst.
what we're seeing here is a metal artifact with a scapholunate.
Oh, they had a
Elevation.
repair maybe.
So this patient who had a scapholunate ligament tear, probably some remodeling due to the abnormal forces. This is metal artifact emanating from this, and this is a scapholunate ligament repair. Robert.
All right, so here, looking at the lunate intraquetrum, it looks like there's a susceptibility artifact or sclerosis across that articulation, right there.
Yeah.
So,
So what do you think this is?
so I think I guess, sounds like we're on the topic of operative intervention. So is it a fusion at this point?
Yeah, this was an operative fusion of the lunotriquetral joint on a low field scan. John?
I'm not sure that that's united.
I'm not entirely sure either. In a case like this, you should probably get a CT scan to try to better visualize the bony detail.
I certainly agree with that.
Yeah. Jason?
All right, so our T1 image on the left, lunate has lost a lot
This
of
is
that.
a low field. This is a T1 gradient echo, a stir, and then another position with a T1 gradient echo.
Okay, looks like the lunate has lost a lot of its normal fat signal there.
Yeah, so you got a lot of
Edema in the capitate and hamate as well.
poor visualization of the cortical margins and the articular surfaces. There's a plain film view. There's something down here. So what do you
Some
think
sort
might
of
be going on here?
sporadic lesion there.
So this patient had surgery, and this is a carpal fusion with what's called a coralline graft, but they actually take bone from here and then they pack it. And then they put the bone in here to fuse the joints. And again, it looks like there may not be complete fusion here. So again, this is a case where you should get a CT scan. John, do you want to comment about carpal fusions?
I frankly myself haven't done maybe a couple, but they're not easy to fix. And to fuse them, you can fuse them all right. But the thing is, the results in terms of pain may continue. And that's
Thank you.
whenever you operate on these, you just never know how it's going to turn out.
Yeah, I haven't seen very many fusions in practice, so I've kind of gathered that
Most of
they're
the
not
time, I think the
really.
guys remove the rows.
You're right. Yeah, I see more carpectomies rather than fusions.
But that's in rheumatoid arthritis and trauma. You try to fix them if you can.
Okay.
But fusions are bad news in many cases.
Okay.
Okay, so here we see the distal ulna dorsally subluxed.
Yeah.
Suggestive.
Now, and that's what a lot of people call it. Remember, the ulna is the stable bone.
Oh,
So technically, what you're seeing is subluxation of the radius with respect to the distal ulna.
hmm.
How much is too much? That's kind of debated, and not everybody agrees. Generally, it's felt that if this is abnormal, if you have the kind of the mid uh, portion of the ulna articulating with dorsal or volar. Usually, it's the dorsal aspect of the radius. Uh, but you know, if there's even a lot less displacement than this, I would raise the question. But this is definitely abnormal when you get to this stage, and there's probably a lot of tendinopathy here of the fourth extensor compartment as well, and maybe some tenosynovitis of the flexor tendons. So there was some papers looking at this. How do you call it? Distal radioulnar joint instability. Just remember that it's going to look different depending upon whether you're uh, 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 pronated or supinated. These are assuming a supinated image, and as you all know, I prefer to image the wrist with MR in the pronated position for the reasons we talked about before. And you can see the two arcs here, and they should be congruent. And when you get instability, you start getting separation from this. Okay, see who's next? Danny? Okay.
So we have dorsal subluxation of the radius with respect to the ulna, and then associated soft tissue edema.
Yeah, this is probably volar. These are probably the flexors.
Oh, okay.
These are probably the extensor tendons with the sixth extensor compartment here, the first extensor compartment, second extensor compartment, third, fourth, fifth. Yeah, but I agree with you. This is too much. This is definitely an unstable distributed ultra. We're not finished yet.
And then this looks like VISI.
Maybe a little to see here, but what about here?
I don't see the lunate there.
Right.
So
So if you just see this, you'd be
or about dislocation.
Dislocation, right?
Yeah.
So, but when you have an unstable distal radioulnar joint, you may have an image that goes through the radius and the ulna, but if the ulna is way back here, what you may be doing is your image plane will be obliqued and you'll go dorsal to the lunate here, and it'll look like you have a lunate dislocation. So it's important to look at the sagittal images. Here, it's certainly not a lunate or perilunate dislocation. It's probably a little bit of a DC, and a lot of this pattern is actually due to the fact that you have an unstable distal radioulnar joint, and the imaging is obliqued here, going dorsal to the lunate. So you just have to look at all the images. Obviously, the little ulnar styloid fold fracture and then you can see distal radioulnar joint instability. Robert.
All right, so we have a 20-year-old female evaluate for TFCC and lunotriquetral tear. On these coronal images, the TFCC and lunotriquetral ligaments, I think, look like they're intact, but there's a DRUJ of fusion. So I'd want to take a closer look there for sure. And here it looks like there's even more fluid in that DRUJ. Dorsally, yeah. Is that, yeah. Is that a sprain of one of the components of the TFCC?
Yeah, so that's a sprain of the volar radioulnar ligament
Okay.
tear. And that's leading to instability and effusion. Okay.
Pro Australian football tackling injury.
It's just the number of tears of the muscle. Again, tears of the cerebral capsule here. Why don't you take this?
Okay. Looks like the radius and ulna are very disarticulated from each other.
Well, they're still adjacent to each other, but not in the right location.
Yeah.
So this is a chronic distal joint instability, and these often become fixed with deformity, and they no longer allow pronation and supination at the joint, where it becomes very, very painful. So you want to pick these up much earlier than this before you have this kind of irreversible degenerative disease of the distal. And here's just another example of the same process. We're using a high field scanner where you can see the chronic dorsal displacement of the radius with respect to the distal ulna, secondary degenerative disease of the distal radioulnar joint, and occasionally you can get fusions even, but this is probably just severe degenerative disease, but this becomes painful. You get a deformity of the wrist and a lack of motion. Okay.
Okay, so here on the sagittals, let's see. Looks like there's bone fragmentation, the distal ulna. Looks like there was maybe an old fracture, and
Yeah, so this is a fracture dislocation. Right. Good. Okay, so let's go on and talk about the ligaments. And the ligaments, the external ligaments, we've already, the external, the intercarpal ligaments we've talked about giving us DC and VC, and then the triangular fibrocartilage complex. So let's go on to the triangular fibrocartilage complex now, important for the fine-tuning motion of the wrist. And a lot of people will use the Palmer classification here of triangular fibrocartilage tears. I don't know of any others. I'm sure there's some others around, but this is the only one that I've seen used. And he has classes A, B, C, and D. Class A is a central perforation. Class B is an ulnar disc avulsion with or within styloid fracture. Class C is ulnar lunate or ulnar triquetral ligament tears dorsally or volarly. And then Class D is a tear or detachment of the triangular fibrocartilage from the radius. So again, we talked about the fact that to really see this properly, I believe you need to image in pronation, and so that you don't get kinking of the triangular fibrocartilage. And when you do coronal imaging, it's along the lung axis, the straightened lung axis of the TFCC. Okay, who's next? Danny? This is an arthrogram.
It looks like there's irregularity at the TFCC.
So there's TFCC, see some
At the
regularity.
mid-dorsal portion?
But do you see it well?
No.
Feel comfortable with what you see? Why do you think you don't like the images?
Palmer goes back to 81 before MRIs.
Right, right.
So that was arthroscopic.
Yeah, and arthrography.
Oh, it's
Or CT, whatever.
Yeah.
oh, that's the trick, huh?
Okay. So what you see here is if you go down the long axis of the triangular fibrocartilage, you don't see the ulnar styloid, and therefore you don't really see the peripheral attachments, the upper and lower lamina. And then here's the mid-dorsal, just the periphery is just kind of a mess here. And then when we actually go dorsally, what we see is the ulnar styloid, but now we're not seeing the triangular fibrocartilage. So this was done in supination rather than pronation. And I just don't think you can reliably evaluate the triangular fibrocartilage if you image in supination. So that's a supine arthrogram.
Maybe the patient couldn't pronate.
No, maybe that's the case, but I remember this case. This was because the MR technologist didn't know the difference.
Maybe his brain wasn't working.
And the funny thing about it is, if you look in the anatomic literature, they'll always show you the anatomic position. The anatomic position is in supination. But if you look at all the diagrams in almost all of the anatomic literature, they actually show the wrist in pronation, so that you can see the triangular fibrocartilage nicely attaching to the ulnar styloid.
Yeah.
So yeah, I think this is an important distinction that wasn't always made. Hopefully it is now, in radiology imaging. So this just shows the triangular fibrocartilage, its attachment to the ulnar styloid, and we'll talk here in a minute about the different attachments here. Here's the radial attachment, which actually attaches to the articular cartilage, not directly to the bone. So there you'll have high signal intensity between the triangular fibrocartilage and the bone, because it attaches to the cartilage. On any sequence that shows cartilage is high signal intensity. And there's, again, kind of a diagram, and this shows the distal radioulnar joint space, here called inferior radioulnar cavity. Here's the prestyloid recess, which we talked about being overextended if you do arthrography. This is what it looks like in gross cut specimen. Here's that articular cartilage, which will often be a bright signal intensity. And some people will misinterpret this as being fluid going through a tear when it's just the articular cartilage. There's the central disc, and then there are kind of two chief attachments to the periphery here. We're not seeing the ulnar styloid here because this is sectioned obliquely. But that's what the distal radioulnar joint and triangular fibrocartilage look like. Go to a little higher resolution diagram. This shows the disc proper attaching to the radius. Here are the two upper and lower lamina. Now remember, in the anatomic position, the arms are down at the side, so the upper lamina would be the proximal one. The lower lamina is the distal one. One attaches to the tip of the ulnar styloid, the other the foveal attachment proximally here. And then there are other attachments. There's the ulnar lunate ligament attachment, which are dorsally and volarly, part of the capsule of the joint. If any of those are torn, it changes the type of injury to a type C. And then you've got the lunotriquetral ligament also, which would change it. And then the meniscal homologue is a kind of ill-defined soft tissue, fibrocartilaginous, mainly fibrous tissue going distally in this location. Now, if we look at MRI, Here we can see, let me just check here. Yeah, I think this is volar. Yeah, volar. So here's the TFC. There's the ulnar lunate ligament, volar ulnar lunate ligament. The ulnar triquetral ligament would be up in this particular area. If we go one cup more dorsally, we're in the central portion of the disc. There you can see the articular cartilage and the attachment of the triangular fibrocartilage to the articular cartilage. Here we can better see the ulnar triquetral ligament extending here, the meniscal homologue coming up through here, and we're not quite to the point where we can see the upper and lower lamina. And then here we can see more midline as far as the disc is concerned. There are a hyaline cartilage where it attaches to the radius, and then we have the lower and upper lamina at their attachments to the ulnar styloid and fovea. And then if we go on the sagittal plane, you can see the volar ulnar lunate ligaments and the radial ulnar ligaments coming down here on either side, the disc in the center. And if we go a little farther out, we can see part of the ulnar triquetral ligament and some of the meniscal homologue there. Okay. Okay.
That's what keeps the bones together.
There you go. I don't know who's next. Anybody? Okay, Robert.
All right, we have a 42-year-old female with pain after injury on a 1.5 Tesla scanner. There's a lot of, increased signal within that TFCC. I don't see a discrete tear.
Yeah, see, I have very poor contrast, which is why we don't use these images anymore, though we could get nice thin cuts, and we're kind of deciding whether the higher through plane resolution was more important or the contrast, and finally decided it was the contrast that was more important. Yeah. So what do you think here? Here's a gradient echo, and here's a PD fat set.
Yeah, on the PD fat set, it does look like there's a lot of increased signal with that. Was it the upper lamina of the ulnar attachment?
There you go, right there. And you can see there's also an abnormal effusion in the distal radial ulnar joint space. And then this was a peripheral tear of the foveal attachment. And the foveal attachment of the two, the fovea is more important than the distal in terms of stability. Okay, Taysom.
All right. Pain and trauma. I don't see a clear attachment to the radius on the TFCC there in the star image.
Yeah. Now, this is a low field scan. Now, I used to put this in because what I used to say is that you really need to look at the orientation first off using the axial images.
Okay.
And here you can see this is actually a supinated image. So you have to be very concerned about evaluating the triangular fibrocartilage when you're dealing with a supinated type image. We can see that there is instability of the ECU here in the sixth extensor compartment. So I'd be a little bit concerned about what I see here if we're imaging someone who's in a supinated position.
Okay.
So is there a perforation here? Now, so we brought this patient back and then imaged them in a pronated position. So what do you think in the pronated position?
Still looks like there's a defect there at the.
So now we can see it's in the pronated position. The ulnar styloid is kind of collinear here, with the radius like we talked about before. It's not dorsally positioned with respect to the radius, but again, it's the radius that moves, not the lunate. And now we can clearly see that there is a tear in the triangular fibrocartilage. So look at this image versus that image, and it helps you recognize how important it is to have the patient properly positioned when you do wrist imaging. Okay.
Okay, 34-year-old male, wrist pain for 9 months after an injury. Yeah, the central disc, the TFCC, looks like there's a tear.
So that looks like a little central perforation, right? With fluid going into the distal radioulnar joint. And there on the next image, we can also see it. And here we can see there's the articular cartilage of the radius, part of the TFC, central perforation, peripheral portion of the triangular fibrocartilage disc. And gradient echo, or this is a Fiesta gradient echo, 1 millimeter isotropic images, and you just don't see it very well. Contrast is really more important than spatial resolution for most of the imaging we do. And here we can see a little bit of fluid and the triangular fibrocartilage, but we're better seeing it with the more conventional images. So we've stopped doing these a number of years ago. So this turned out to be a central perforation. Let me just set this. So this is a low, John, were you going to say something?
No?
Okay. So this is a low field scanner where we can actually see the lower and upper lamina here nicely at their attachments to the fovea and the distal tip of the ulnar styloid. On a low field scanner, here we can look on a 3T when they first came out. We can see this is, I think that's going to be the ECU. So we're dorsal here. See a little bit of signal intensity within the disc, a little bit of degenerative change. If you go to the next cut forward, we can see the upper and lower lamina here. They're not real black, so there's some degenerative change of the lamina. And then going more closely, we can see the ulnar triquetral ligament up here, a little bit of degenerative disease in the central disc. If we keep going forward, we can see part of the homologue coming up here proximally. And then finally, yeah, so it just has some anatomy. Let's see, who's next? Okay.
44-year-old fell, rule out intercarpal ligament tear. Kind of looks like, yeah, there's a little bit of fluid there. Distal radioulnar joint.
And here it looks like the triangular fibrocartilage looks like it's pretty intact.
Yeah.
If we go more forward,
And a 44-year-old is that's not abnormal, is it?
in someone who's symptomatic, I'd be a little concerned if this is all I saw. I didn't really see anything else. Well, type 2 lunate, but that's okay. So we just look further, John. When I saw this, and if this was all I saw, I wouldn't even mention it. I would just pass it as normal. But when we look more vulnerably, we saw this image. And Danny, what do you think of this image?
It looks kind of medially there might be a little defect in the TFC.
Over here.
Yeah.
I'd be more concerned up on top.
Yeah. So this is actually the foveal attachment of the lamina. We can see that it's intact here, but maybe it's not intact there. And if we go to the sagittal images, we can actually see that there's a defect back here, and that this was a partial tear of the upper lamina. Robert?
All right. So here we have some 3 millimeter images, T1 and STIR. And on the T1, it looks like there may be a perforation of that central disc, but on the STIR, I don't see it as well there. It looks.
Okay. Concern that. So let's go to the 0.9 millimeter thick contiguous images done by gradient echo on this low field scanner, and this is what it looked like.
Yeah, that looks more like a tear to me. I mean, it looks like there's a defect of
And
that
this was,
articulated disc.
and this was a tear seen surgically. So, I mean, yeah, both spatial resolution and contrast is important, but you have to have the contrast. And at gradient echo, we can actually get good contrast at low field, but not at high field. So were some advantages when we did a lot of low field imaging of the wrist back when we used these thin cut gradient echo images, but there are such a few. There are very few areas in the musculoskeletal imaging where low field has any advantage. That by far it's much more important to image in the musculoskeletal system using high field imaging, but just be aware that there are some limitations. And now at 1.5 and 3T, we can get thinner cuts with reasonable contrast. I still think we have trouble matching the old low field gradient echoes for the TFC, but we can certainly do a very good job even without arthrography now. Okay. Jason, you're.
Yeah. Okay. Tear or no tear?
Now these are low field T1 on the left and stir on the right.
All right. Well, just heading towards the homolog.
These
there's
are
some
3
increased
millimeters skip 0.5. Okay, the homolog, we're not quite in the right position to see it. So the concern here is what's happening here.
Okay.
And there's a little bit of irregularity there, which we can't really resolve
Yeah.
very well. If we go to the gradient echo images, that area looked like this.
Okay. So full thickness perforation there.
And this was a full thickness perforation right there. Yeah. Okay.
Okay, we have a 58-year-old male athlete with wrist pain. I see fluid in the distal radial ulnar recess. The central disc looks intact, but that foveal attachment, that looks irregular. Maybe there's a tear of the ulnar triquetral ligament. There's a defect there.
So this is an arthrogram. This T1 fat set. You can see there is contrast extending into the distal radial ulnar joint, so you really have to be concerned about a tear.
Yeah.
And if we go to the thinner cuts, in this particular case, you can see the tear better here, coming across right in through there. And that's, if it's a tear that's only a millimeter or two, then if you have a 1 millimeter image, you're more likely to get better contrast through it because you have less partial volume.
Okay.
And so this was a surgically confirmed tear of the triangular fibrocartilage.
That's probably debrided.
I don't remember what they did, John, but
That's 58 years old, John. So
yeah, right. Okay, well, why don't we stop here and we'll finish the instability of the wrist up tomorrow. Oh, and John won't be joining us, unfortunately, but
yeah, I'll miss you guys tomorrow and
Yeah.
the weekend. So
and
hopefully I'll be with you on Monday.
John, I've got a bunch of lectures, a bunch of meetings on Monday, so we will not have lecture on Monday. So our next lecture will be Tuesday.
Okay.
Alrighty? So see you
See
guys
you on Tuesday then.
Thank you.
Take care, everybody.
Thank you.